Well, good morning, good afternoon, and good evening to everyone. We want to thank everybody for joining us for our webinar today, Lessons from Healthcare and Higher Education, Changing Culture in the Role of Leadership. My name is Karen Luce. I am the Director of Learning and Development here at Dennison Consulting, and I'm your host for today's webinar. We're very happy to have with us Dr. Tom Fairchild of the University of North Texas Health Science Center, and he's here to kick off a two-part series that we're doing on changing culture in healthcare. Before we get started, I wanted to quickly go over just a couple of technical things. We're going to present today for about 40 minutes and then use the remainder of our time to go over some questions that have been sent in by you, our audience members. On the right-hand side of your screen, you'll see a control panel, and you can use that to send in your questions. We ask that you please send in your questions throughout the presentation rather than waiting for the end. This gives us some time to organize them, and then that helps us make the most of our question and answer period. We'll try to get through as many questions as we can, and we do apologize if we don't get to your specific question, but we'll make every effort to follow up with you after the webinar. I also want to let everybody know that a copy of today's webinar and the PowerPoint slides are going to be archived on our website, so if you'd like to view them later, they will be available to you. We will send each of you an email once they are up there. So, now to get started, I would like to introduce to you Dr. Thomas Fairchild. Dr. Fairchild is the Vice President for the Office of Strategy and Measurement for the University of North Texas Health Science Center. He received his BS in Management and his MA in Sociology, both from Wayne State University right here in Michigan. He completed his PhD in Sociology with a specialization in aging from Wayne State University. As Vice President, he is responsible for establishing and maintaining an effective strategic planning process for the Health Science Center, and through that developing performance improvement initiatives that span across the institution. Dr. Fairchild recently presented at the 2011 Dennison Best Practices Forum in Delray Beach, Florida back in January, and his story is also the subject of one of our case studies, and we'll send each of you a link to that later on today as well. And with that, I would like to thank Dr. Fairchild for joining us and introduce him to all of you.
Thank you, Karen. Again, good morning and good afternoon and good evening from Fort Worth, Texas. I'm delighted to have an opportunity to share with everyone our journey in how we've made use of the Dennison to really drive our culture here at the Health Science Center in Fort Worth, Texas. Let me begin by trying to give everybody a sense of what is a Health Science Center. As many people say, when you've seen one Health Science Center, you've seen just one Health Science Center. Our academic institutions are really core, as you would expect, to the Health Science Center. We have our Texas College of Osteopathic Medicine, the Graduate School of Biomedical Sciences, the School of Public Health, and the School of Health Professions. The order that you see there is basically the order in which they were founded, with the original school over 30 years ago being the medical school. Most recently, under the health professions, we've added physical therapy, starting that program just last fall. 1,500 plus students, over 415 full-time faculty. We have approximately $42 million this fiscal year in research awards. For our clinical services, we have approximately 588,000 patient encounters last year, and in the last 10 years we've doubled our campus square footage, driven in large part by really student and growth in our research areas. What I want to do today is to try to share with you probably four main ideas. First and foremost is the role of leadership in attempting to change a culture, the importance of first unfreezing the old culture, what we did in terms of developing a new culture, and what we're in the process of doing of refreezing our new culture. This is a journey. We've started it 5 or so years ago, and we still have some ways to go. As indicated here on the slide, not everyone is too keen on change, but the reality is if you're involved in healthcare and higher education today, you really have to change. And I think we know around the world, just using education as an example, whether it be in Europe with the recent marching in the streets and protesting in the United Kingdom, or whether it be in the United States, there's dramatic changes that are facing healthcare and higher education. Obviously, for all of us, Confucius probably had it figured out that it's easier to ride the horse in the direction that it's going than to try to change. No one is really too keen about that change, and in order to drive change, it's really important to have a transformational leader. We were very fortunate back in July of 2006. Dr. Scott Ransome was selected by our Board of Regents. We're part of the UNT system, and was selected by that Board of Regents in a committee here on our own campus, the Health Science Center campus, to be our new president. At the time when he came on board, these were basically the challenges that we had started to address, we're thinking about. And if we fast forward to today, I think everyone would recognize that these changes now have come in complete focus and are bearing down on us in unprecedented ways. The competition for high-quality students continues to grow. New research models that drive funding for us, the bulk of our funding, as it is for most of higher education, comes from the National Institutes of Health. And they have and continue to make, under Dr. Collins, the director, significant changes. Challenges of reimbursement for health care. The federal changes in terms of the Patient Care Affordability Act is just one example. But in our own state, which we are now in a budget cycle now, we have our budget is set every 2 years by our legislators, and we're in session right now through the end of May. And challenges there for the Medicaid piece of funding for hospitals, as an example, and physicians. That's just driven in part by the competition that continues to grow in the healthcare marketplace. And of course, the huge thing that is relatively new for higher education, and it's driven in large part by the Department of Education and by organizations that are responsible for, through the Department of Education, that are responsible for essentially accrediting higher education. And so for accrediting bodies, words like accountability and transparency that really weren't the norm are now really their buzzwords, along with legislators and family members as well. So within that type of a climate, we had a 5-year strategic map that was approved by our Board of Regents in September of 2006. At that point, we had a session, January of 2007, as I indicated now. January of this year, 2011, we had another session that started. And back at this point in time, in 2006, it was pretty clear to Dr. Ransome and many of the leadership team that really business as usual would not work. You may have noticed there with Dr. Ransome, in addition to being a physician, he also has an MBA degree as well as a Master's of Public Health. And through his previous experience, he certainly had attained a high degree of business acumen and was very concerned about how best to address the challenges that I just shared with you. One of the things that he attempted to do was really to create a sense of urgency and to get everyone to recognize the need for change. I think any of you would appreciate, for any organizations you work in or have worked with, that as the previous cartoons have indicated, not everyone is too excited about change, and not everyone necessarily appreciates the sense of urgency. You can probably take those ideas and double the impact they have within higher education, which historically and probably by and large, most of higher education today is still very reluctant to change from what they have been doing. Of course, because of budget issues and concerns at state legislators, that change now is being driven by them, as well as I mentioned, in terms of accrediting bodies. But in any case, we had to do something different. Business was not going to work the way that it had. Starting at that early phase of this process, the executive team was made up essentially of deans and vice presidents. So we had the academic element, and then we had the academic support side, as well as our clinical piece, made up that executive team. for most of those faculty and staff, they really did not embrace the sense of urgency to the need for change. They were doing what they had done, and they were doing it quite well. They weren't necessarily looking over the horizon and recognizing that some of the rumblings that were occurring in Washington, as well as with our own state, were beginning to impact higher education. Clearly, the issues as we move forward that delayed some of that sense of urgency and the need for change as were the stimulus dollars that went into the state budgets, which pretty much mitigated any cuts until now for us and for every state. And then some of our key leaders, we discovered, really probably didn't have the skills and knowledge to assist in how to effectively implement the mission and strategic plan. Again, if those of you that may not be familiar with higher education, but historically on the academic side, someone that is moved into a chair of an academic department or becomes a dean doesn't necessarily achieve that position because of their skills in management or finance. They achieve those positions basically because of their skills that they have within the academic world, research and publications. So there clearly was a sense that some of the people that were part of this executive team probably either A, weren't that keen in trying to make the change, and or B, certainly needed some assistance in developing and strengthening their skills and knowledge to make the change work effectively. Key to that, we felt, as indicated here by the cartoon, were really our core values. And trying to get people to really reflect on actually what are the core values for the Health Science Center and how those have to be integrated very effectively into our culture. So this is beginning to build up really to the point of trying to drive the change. And really there's three phases that we went through, and we're still going through that, particularly in phase 2 and phase 3. The deployment of what I'm going to describe to you is certainly not 100% across all of the organization, but is certainly taken hold in large and critical areas of the organization, from our clinical practice to our academic, and also including our academic support services. So clearly the first start is unfreezing that old culture, and I've shared with you the sense of urgency, the importance of our executive team, that guiding team, and obviously we need to have a change vision and a strategy. Where are we going? What are we trying to do? We like to think of culture as an iceberg, and everyone's very familiar with the proportions of an iceberg in terms of what's above the waterline and what's below the waterline. The book by Dr. Cotter, Leading Change, is critical for us in terms of what John Cotter has talked about and written about, and continues, I think, to be a very useful guide. So we really looked at those steps as a critical element, and the first thing really was trying to unfreeze this existing culture, which is in a sense depicted here as an iceberg. So the issue of focusing on mission, adaptability, consistency, and involvement, really the elements of the Denison Cultural Survey, and looking at the aspects below the waterline, which really drive behaviors. I mean, that's what essentially culture is doing, as you all know, trying to create change and organizational learning. And start with really a sense of mission, vision, and values. What is it we're actually trying to do? And to get people to really grasp and understand those particular challenges. I think we all recognize that culture is very slow to change. It's no different for us than it is for every one of you in the organizations you work with or work in. It helps us survive. You can think of culture as really a sort of a set of assumptions that are like fence posts. You put one of those in the ground, they don't move very easily, and they help to provide a kind of a definition, a framework for reality. If you put all those fence posts together, you end up with this pattern of assumptions. It's what everyone has heard many times over: this is how we do things around here. This is what we really do. And that's just how business is done. So we have that sense of a reality. So we're inside those particular fence posts, and if we didn't have the sense of reality, if we didn't have that sense of what our culture was for us, you know, you might argue we'd literally lose our minds. We wouldn't be able to function very well in an environment that was constantly changing from literally minute to minute, and you didn't really understand how things were accomplished and what was acceptable behavior and what behavior was not acceptable. So as we all can appreciate, everyone's got to cling very firmly to those particular assumptions. That's the fundamental critical issue of trying to change culture. It is, again, emphasized, slow to change, and that's why this whole effort that we're on is really a journey. The sense of urgency could certainly be expressed by Jim Collins in his classic book where he talks about leaders get the right people on the bus and, in a sense, the wrong people off the bus and set the direction. And that's really what Dr. Ransome and the leadership team was charged with doing in trying to make this change effective and understood throughout the organization. So we started with essentially a guiding team. I mentioned already the executive team, which included the deans, the VPs, and the department heads. That seems simple enough, but remember what I said a moment ago is that not every one of these people, they might have been on the bus, but they may not have been on the right seat. And as it turned out, to nobody's surprise, some of the people did decide to get off the bus. One of the most fundamental changes that we had to make was to get people to realize this quote by Deming and how important it was. In God we trust, all others must bring data. Now you would think that in an environment of higher education and creation of knowledge and the importance of research and providing evidence-based clinical care that people would readily accept this. But the reality was they may accept it in what they do in their lab or in the classroom or in the clinic, but they didn't necessarily accept it as a key element of how we shape an organization and how we drive change within an organization. So that required a sense of getting people to think differently. This is a model that I'm sure a number of you are familiar with. It's basically the framework of the Baldrige. And what we did here is to make a few adjustments, and you'll notice in the outside circle we put culture. But important to appreciate that the starting point for this, again, is leadership. And in our case, if you remember, we talked about transformational leadership that was so critical. So as we went through this process and engaged in this, we had to recognize the critical role of culture, and hence that's driving us to the importance of understanding what our culture was and moved us to the appreciation of having to get some baseline information for that culture. And obviously that's why we're here today and talking about the critical nature of that and the role of the Denison Culture Survey. The other elements of here I don't think anyone's totally surprised with. You may shape them differently. Again, we have sort of embraced this as a framework that works very well for us. So the concepts of the strategic planning, item number 2 there, and the focus in our case on the patients, customers, and students, what have you, the importance of measurement, issues of the workforce, process management itself, ultimately getting us to results. And all of that, as many accrediting bodies would like to say, is trying to close the loop with those results and continuing to make change. So this sort of became for us a simple framework of expressing what we're trying to do for our faculty and our staff, as well as, of course, our students, which is why we're here. From that, we were real believers in anything that we developed. We wanted to have it essentially on one page. And so this became our basically vision and strategy. You may notice from the dates up top, this was revised last summer from when we first started the 5-year strategic plan. And one of the things that I think is perhaps a bit different and important to recognize here is each one of those areas, academic, research, clinical, community engagement, and administration, essentially represents our mission-centric areas. I'm not going to go into each of the items underneath those, but that's really the core elements of our business. Administration and community engagement are deliberately at the bottom because they really support our core businesses of academic, research, and clinical. That's why we're here. That's why I'm here as an administrative position. The other box you see, there's interdisciplinary, where we looked at what cuts across the academic, the research, and the clinical. And those are three areas of expertise that are very important to us. So if you're involved in delivering clinical services related to an older patient in, let's say, our geriatric clinic, there's an implication of that that ties back to the research opportunities that may exist, and of course the education that is shared within the classroom for the first 2 years of the medical student's experience, and then of course even starting in the first year their clinical exposure, but obviously moving through their 4 years of their particular degree. So it's and deliberate in terms of how it's structured. The next slide here, which I appreciate is hard for all of you to read, but you'll have copies of this, is again the key element here, and it's very easy to follow from the previous slide, is this is what we're trying to do for this particular fiscal year, that ultimately if we do this through 11 and 12 and so forth, we'll accomplish by 2015 that strategic plan that I shared with you on the previous slide. Again, you'll see the mission, the vision, and the values across the top, and you'll see the 5 mission-centric areas represented in each one of those particular columns with administration, academic, and so forth. The other key element that I'd like to point out here that will link to the next slide is we were very deliberate in establishing performance measures for the institution. And the goal here when we started this process was to initiate it at the level of the institution, but then ultimately to cascade that down through all of our academic as well as our academic support departments, and ultimately make sure that is aligned with what happens within those departments, say within a college, and further drive that down to be aligned with what a faculty or staff person may do. So there's a very deliberate effort of setting this up in such a way that it can be cascaded down through those performance measures. So a simple example to think about here would be, say, student enrollment. So we have an overall goal for the institution, a performance measure, but that goal could be broken out by schools and broken out then within those schools by departments. And so we would do that with other appropriate measures as well. Research, say, could be a similar example. Clinical services could be another example. So focusing on developed essentially a performance measure page, single page. So again, the commonality is now hopefully becoming apparent. So on the far left side, you'll see again the 5 mission-centric areas. Academic affairs, research, so forth, down to administration. Again, here administration is at the bottom in a very deliberate way because it supports everything that is above that, just like community engagement. What we do here is, as you can well imagine, is we set targets, which are on the far right, and then we look at this for each of our 4 quarters. And on a quarterly basis, we look at our results, and we define success by how close we are or are not to that particular target for that quarter. And then we highlight that, as you've seen many times on a scorecard, with a red, a green, or a yellow. So it's a very visual way. Now, this is simple enough, but hopefully you can get an appreciation now of, by doing this, everyone who's responsible for those mission-centric areas. So as an example, under academic, that would be the provost. Under the research, that would be the VP for research. Under clinical care, it would be the executive VP for clinical services, are now being held accountable. And this is shared at the level of the executive team. So there's accountability and transparency. And this document is available on our website for all faculty and staff and students to see. And getting people to accept that accountability and to recognize that you have to then look at what you need to do within your organizational element to drive change is really very important. So moving forward, then we recognized that we had to have a baseline of where we are at in terms of our culture. And again, as I suggested earlier, the 4 areas, for those of you that may not be familiar with the dentist, is the mission, the adaptability, involvement, and consistency. So we had been at it a little less than a year, probably closer to 9 months, and we, in early or late winter of 2007, gave the Dentist out to our faculty and staff, all faculty and all staff. We made it available also as a hard copy if need be. And the results speak for themselves. We did a great job getting us going in terms of understanding the mission area, particularly sharing the vision, clarifying goals and objectives, strategic direction and intent. We were really focused on that as a critical starting point. And of course, the mission, value, and vision you'll see reflected, I think, in some favorable effort at that point in terms of our core values. The other areas, obviously, is an opportunity for improvement, or an OFI, as we might say, within the performance improvement area. So we had a lot of OFIs. We had the ability, for those of you that are not familiar, you like to look at this in a sense as a lollipop. In other words, the further out those colors go, the better off you are within each one of those quartiles. So the goal is obviously to be all the way out, as an example, into the last quartile, let's say, for vision or for core values. So we're pushing out from the center, and the further out you are, the better off you are. So clearly we had some work to do. We had to have a sense of people at this point, again, resistant to change. We had to look at ways that there were some people that were very cynical about this effort, felt, well, we'll just kind of wait this out, this will pass too, we've seen this type of thing before and it will go away. But indeed it wasn't going to go away, and we really entered then into the second phase, which we had to start to create once we had the results of the Dentison, because the Dentison results are very effective and really designed to start a conversation and then decide what to do. And so once we moved into phase 2, for us, the roadmap that we used was the culture survey. Very strong believer in the importance of this, because otherwise it's rather haphazard, I think, in terms of trying to decide what it is you really need to do. So some of the things we started to focus on here, again, going back to the Cotter in terms of the stages of change, is the importance of communication. We had to get buy-in beyond the executive team. We had to really build the skills and knowledge and empower other people to act. We had to not only produce, but we had to celebrate some short-term wins, and we had to create what we thought and we labeled a leadership coalition. This became an important element for us. So we expanded the executive team in the sense of leadership. So the executive team stayed in place, and now we created a leadership team. The leadership team moved us up to somewhere closer to 80 people and took us down below the level of a dean to, on the academic side, as an example, a department chair, and on the academic support side, took us down to a department head or a director. So we were able to move out to others that were decision makers and that were important if we were going to be successful in our efforts. Another critical thing we did, and we continue with both of these today, is the strategic thinking councils. Each of those councils, again, fall into one of those 5 mission-centric areas. And those councils were composed of individuals who really mostly were at where the rubber would meet the road. So we made an effort to reach out and expand the input to, as an example, not just the chair of a clinical department, but to get perhaps a nurse or a front desk individual who's dealing with the patients as they would come into the clinic to participate in these thinking councils. Back at this point, we were meeting on a monthly basis because, again, we felt it was important to try to move forward and to drive the change. Oops, sorry here. Seems to be going the wrong way. Okay. Well, all right. Here we go. So our third phase of this was to try to refreeze that culture. And the key here was, again, you can't let up. As I said, we're still on this journey. We had to use this as a way of creating a new culture. That leadership coalition that's under phase 2 helped us move into keeping that leadership group, which meets once a month. But also, remember I mentioned we really needed to build the skills and knowledge of these leaders. And so we developed and still are continuing with and becoming more focused with our Leadership Development Institute. And the real purpose of that is to help to coach these individuals to build the skills and knowledge that they need. Our job is to kind of keep a pulse of what's happening with the Leadership Development Institute, or the LDI, and the continued focus on improvement becomes very important to what we're trying to do in that third phase. So I like this quote because I think reflects very well many of the challenges we face. It's difficult to get people to think their way into a new way of acting. Instead, people must act their way into a new way of thinking. And that really is what I think drove a lot of our efforts and helped us shape essentially finally the development of leadership model. And on the left side here you see again the elements of the denizen, the organizational culture. And on the right side is what we call educational excellence. For those of you that are familiar with this, you would see this again similar to what the Baldrige is focusing on. But we tried to make this fit within our culture using terms and ideas that were acceptable within clinical and higher education, clinical care and higher education. And the leadership development is really the bridge between these two particular areas. So if we're going to be successful in creating and refreezing the new culture, we had at the same time to focus on this aspect of educational excellence, continuous improvement, and we had to do that through developing the leaders within our organization. So for us, the model that we use is reflected here with competency-based in terms of focusing on knowledge, skills, and attitudes, moving up the steps to excellence, trying to help people make better decisions, improving the quality of their decisions, having people, again, hold themselves accountable and emphasize their hold themselves accountable, and ultimately putting those people into a better position to actually lead the organization. It really, for us, was very essential to do this. So we expanded what we did, and here's some examples with the leadership team programs that we initiated back in fiscal year 2007. Our fiscal year is essentially from September 1st through August 31st. I mentioned the strategic councils. We really pressed on faculty and staff evaluations to make sure that we not only improve the process, we help people understand the critical importance of it, but they were done systematically and on a yearly basis. We developed a budget resource allocation model. This was done with the input of the leadership team, the executive team. We worked very hard to engage as many people as possible so they felt a sense of ownership. We looked at some different ways of trying to assess change. A couple of tools are mentioned there. Obviously, the denizen culture results were critical. We worked real hard with that issue of alignment because we wanted to make sure that everyone really understood it. Some of the other topics we looked at were just leadership themselves. We wanted to give people a sense of who they are, try and help them better understand how we are financed and how you have to implement strategy. We continue to move forward with those efforts, and here you'll see some of the additional topics that we have engaged in up through 2009. Again, call your attention to not just what happens at a higher level, such as government affairs for 2008, but trying to help people understand themselves and building teams using the Myers-Briggs, the 5OB, trying to give them a better sense of who they are, but at the same time what they need to know within the larger environment in which they actually work. Communication is critical there, and we've continued to focus on that. You'll see in 2010, with the communication area, we moved through crucial conversations, started to drive more on performance management. This year, we've actually done a carve-out, and we're looking specifically at development of our chairs. We've done already programs here on campus and have more planned this year. One of the things, as I mentioned, is that first bullet under chair development. A lot of times people transition to this area of responsibility, whether it be a chair or a dean, and really don't understand what the role is in terms of academic management and what it is skills and knowledge they must have to work effectively in that particular position. So we're working hard in developing that expertise. Some of the success that we've had, we're very, very proud of this. From U.S. News and World Report to Annals of Internal Medicine is the best in Texas in terms of the social mission list. Third bullet there is very important for us within our medical school is we have over 55% of our graduates enter primary care residencies in the United States. These are things that we have used as through the efforts of our faculty and staff as a way of celebrating many of the efforts that I've shared with you. Trying to refreeze the culture, that last step, we continue to do the 360 evaluations. We actually use the Dennison 360 tool for that. We feel it's a very good tie with the culture. There's a great overlap, and it helps to coordinate and align efforts of individuals with the goals of the organization. I've mentioned the LDI, Leadership Development Institute. We've expanded that now to include management development programs and supervisory level programs. Dramatically improved and expanded our new employee orientation onboarding process to try to make sure that not only from the hiring stage but to the initial few days on campus or week in the clinical area, it's actually longer than this, to ensure that they really have a good sense of our mission, our vision, our values, our strategic plan, the importance of performance measures and what we expect people to do in terms of their own accountability and performance. I've mentioned the strategic thinking councils. We now meet on a quarterly basis and take much more of a strategic focus than we had when we first started. That seems to have worked quite well. At each one of these we'll be doing here starting next week for the second quarter. We'll be looking at those performance measures, asking ourselves where we've need for improvement, what it is we need to do in the balance of our fiscal year. Again, a way of holding people accountable and ensuring alignment from top to bottom. Performance evaluation I mentioned for faculty and staff dramatically have improved that process. We now do a yearly, we're just finishing up our faculty staff survey. We do a student survey. Of course, I've mentioned the Dennison. We're in the throes now of doing that right now. That actually closes here in the latter part of this week. And then we've now created a Center for Learning and Development, which is a support for faculty development. So a tremendous organizational commitment to improving the skills and knowledge. The Department of Marketing and Communication, some of the things that we're doing now is the importance of communicating what we're doing, whether it be Facebook or tweeting. We've created communication teams, which we never had before. We have a yearly progress report that we share. Daily news is something that I'm sure many of you have in your own organizations, calling it something different, but we use that as a tool to drive out critical information across the entire organization. So these are some of the examples. Dr. Ransome has luncheons with opinion leaders, and when I say opinion leaders, I don't mean by position. I mean these are people in the organization that others respect. They may not be in a position of power, but they've gained respect through their knowledge, their skills, their tenure with the organization. We meet with all the service directors on a quarterly basis. After every one of our Board of Regents meeting, Dr. Ransome has a town hall meeting for the entire campus. And we have created a Board of Visitors, which are individuals from across the United States who represent the various aspects of our particular business. So that can be research and clinical. They are within the field of higher education and clinical care, as well as community leaders who have knowledge and awareness of the various programs and services that we actually provide. This has been extremely helpful. So here we are, or we were anyways, from 07 to 09. Again, I think the results speak pretty strongly. We were certainly thrilled, but again, you always have to take that breath and say, okay, if we look at 2009, much like we did in 2007, the results in 2009 helped to start a conversation, and then we begin to act, and many of the things that I've shared with you are really driven by the results that we looked at here in 2009. So if we come back in less than a month from now, we'll have 2009 on the left, we'll have 2011 on the right, and we'll say, okay, what is it we need to do now? Obviously, we still have some work to do. Creating change, I would point to, is certainly under adaptability, which in one way is not surprising for higher education. It's always not the most sensitive to the marketplace and the need to change. But that said, the results we feel are quite indicative of the efforts that we've made. The importance here of the denizen is to able to have something that is very systematic, has good reliability and validity, which when you're dealing with many scientists and so forth is very important for them. The new culture, alignment and accountability. This is a simple way of envisioning what we're doing. We're trying to drive it down from the level of the Health Science Center, pushing it down through those tactical initiatives that I shared with you in our performance measures, moving that through the level of the dean or the vice presidents, departments and programs, and ultimately faculty and staff. The linkages is important. We're trying to change behaviors. We're trying to certainly maximize our resources, particularly in the climate that we're in now, and trying to increase the levels of accountability. What are some opportunities for improvement? These are a few, I think, that are important. You have to balance the needs of individuals versus the speed of driving change. One of the challenges, I think, in any organization is there are those that are going to be very resistant to change. They can still are individuals that are making a significant contribution to the organization, but on the other hand, you still have to move beyond that, and you have to appreciate the huge challenge in trying to make that work. Keep in mind, in higher education, we have something that you're familiar with, I'm sure, called tenure. So it's not like in an organization where you can simply say, if you're not going to get on the bus, we're going to help you get off the bus, because that's simply what is not possible within higher education, for faculty at least that are tenured. For us right now, the second bullet is huge. How do we maintain the momentum in these challenging economic times that we are in? And that's a big issue for us, as it is for anyone in higher education and healthcare across the United States today. We're not alone, but we're certainly in a better position to deal with that as a result of what we've done. And I think recognizing that there are no sacred cows. You can't keep anybody out of this and decide that because who you are or what you've done in the past is any guarantee of what you're going to be able to contribute to the future. So that is the conclusion. I welcome any questions and comments that you might have, and appreciate your attentiveness as I tried to share with you our journey, and we continue on that journey, and we'll be doing so for certainly the foreseeable future. Thank you.
Well, thank you, Dr. Fairchild. I do have a couple of questions that have come in. One came around the beginning of your presentation with Dr. Ransome and his role in creating a sense of urgency. Are there some particular things that you can point to that some actions that he took that helped him create that sense of urgency and drive it through the organization?
Yes. One of the things that we had been faced with when he had arrived is, as I mentioned, we have a practice plan, clinical practice plan, and it contributes to about 40% of our revenue. And at the time, that practice plan was close to life support. We were within a few days of reserves, and the reason that it really hadn't been brought to anybody's attention in the sense that we need to do something about it is that at that period there was always the available money at the end of the year to put back into the practice plan to bring it to a sense of, okay, we're okay for this year, we'll do better next year. He chose not to do that. He chose to be very direct with that and to say this is not an acceptable way in which we can continue to behave. And he highlighted for the clinical side of our operation specifically how this was not a acceptable way in which we could continue, but also started the process of making others across the institution, whether they be in the School of Public Health or the Basic Sciences, appreciate the interdependency, so that those dollars that might be used to offset the deficit were dollars that could be used perhaps to expand growth within faculty in basic science or public health. So he made people appreciate that we are all in this together and that essentially it's unacceptable to continue to take the reserves and shift those reserves into making the financial performance of the practice plan balanced for a particular year. That was probably not the only thing for sure, but one of the most significant things because of the impact it had on our total revenue. I think the other thing that he focused on that comes to mind would be I mentioned to you the issue of evaluation of faculty and staff on a regular basis. That wasn't done. It was really driven more by the dean and how important the dean thought that might be on the academic side, or the vice president on the academic support side. And that was unacceptable. He made it very clear that, we'll revise the forms, we'll do whatever we need to do, but people are going to be held accountable, they're going to be evaluated, we're going to set goals. So those are a couple of examples which I think helped to kind of shake people up early on and say, well, okay, I guess business is not acceptable as usual.
Okay, thank you. It seems that the change was primarily driven from the top down. Is that true? Or are there other things that swept more broadly across the organization?
Well, I think early on, again, if you recall back to that one slide that essentially shows the framework of change in educational excellence and culture, and of course the first box that is there is leadership. Dr. Ransome was hired to be a transformational leader. The Board of Regents recognized the problem with as an example, the practice plan, and found that unacceptable. So initially, I would say that it was clearly first and foremost driven by leadership. Now, as we've moved forward, some of the naysayers have recognized that state budget cuts, the lack of stimulus dollars anymore to support the state budget and so forth, changes within healthcare reimbursement, those external factors have made others realize the sense of urgency. So it's really a culmination of things, but it truly, I would say, when we started this process, if it wasn't for the change of leadership and the direction that Dr. Ransome decided to go, we would be changing now, but we would have been changing mostly because of the external factors and specifically the budget constraints that we're faced with here in the state of Texas and impacts on higher education.
Mm-hmm. Okay. So. Well, while we're on the topic of leadership, you had talked about getting some of the people who didn't have some of the right leadership skills, the skills that they needed. So how did you support developing those needed skills for the executives, and were there expectations set around the timelines for that performance? Were exceptions given for people who needed that extra work or that extra time to develop those skills?
I think the first thing that we had to do as an organization, and that we did, is to move beyond a verbal commitment to growth for our leadership and to support that verbal commitment with financial resources. So the energy and the dollars that we put behind the development of our skills and the knowledge of our leadership team, our deans, our chairs, our vice presidents, department heads, and so forth, in large part was because we, for the first time, really had resources available coming out of the President's office that were broadly committed and that were part of a systematic plan. So we talked about, I mentioned the Leadership Institute, which had flown out of really the leadership team. The other thing that helped us immensely, again, I mentioned the importance of outside factors and accrediting bodies. So our accrediting body had put in a requirement for essentially what they call a Quality Enhancement Plan, or QEP. That particular plan has to focus on things that happen in the classroom, whether it be in the medical school, graduate school, whatever. And key to that was faculty development. So at the same time, the institution had started the process before we were really heavily engaged in our accreditation process of making a commitment for resources and people to the development of our key leadership team, we found that our accrediting body helped move that forward even at a faster pace, with a particular focus even broader than that leadership to faculty overall. So it really was probably a couple of factors there that got us to this point. And to your question about was there, certainly efforts made to recognize that people are going to learn at different pace and have different needs and requirements, absolutely. We found certainly, and still to this day, are working on just having recently completed the 360, looking at different kinds of programs and skills, whether they be part of a formal program that we offer here or people pursue individually on their own, and we support that as best we can. So I think what we've been able to do is now, over time, we've gotten that idea of support beyond just out of the president's office, so it's now is flowing down to a school and a dean willing to make a commitment financially and time-wise to a chair. So within our medical school, as an example, he has created what started last fall, an academy of medical educators. These are 40 faculty that are clinicians as well as basic scientists that every Wednesday morning they have the time allocated and supported by the dean of the medical school to improve through faculty development their ability, say, to teach and to learn. So it's a combination of things that happen, but I think we created sort of this wave of acceptability that you have to go beyond just saying, yes, you should get additional skills and knowledge, to really showing people and helping encouraging them ultimately to do it themselves.
Okay. So looking back over the last 5 years, if there were something that you could do differently, what do you think it would be? What is the biggest lesson learned by you and the organization from this process?
That's a good question. I think probably the one thing that we struggled with, and it's resolved itself now, but I think it's back to that opportunity for improvement that I mentioned in terms of no sacred cows. It was very hard to challenge individuals who had a high profile, they were in a leadership position, say as an example a department chair, and they were quite successful through their, say, research endeavors, but by the way, they were in an academic management or leadership position. And trying to work with those people to effectively help implement a strategic plan, and to see their importance of what they do in helping the entire organization achieve its initiatives on a yearly basis, its performance measures, and ultimately contributing towards the strategic plan. I think that, and again, I mentioned the importance of tenure within higher education. So if you have a clinical chair as a tenured faculty member, and they're quite successful in their clinical practice, they might also be doing research, and try to get them to embrace these ideas. It takes a lot of carrots, and sticks, we don't really believe in that in any case, but certainly those are not going to work. And it's trying to work with those types of individuals to help them move beyond and see the benefit of changing, in a sense, how they think, and getting them to begin to behave differently. So I think that's sacred cows. It's every organization has them. We're not unique, and I'm not suggesting just because we have tenure we're unique, because there are people that are in positions who, they may not be tenured, but they'd be very hard to get rid of for a lot of different reasons. But I think that's just a huge, huge thing, and trying to get individuals to see the importance of what this change is and what it means to them. And it's really a challenge when you have those sacred cows that are just so resistant to it, and sense and know that they're sort of protected for whatever reason.
Okay. Well, I think that's about all the time we have time for questions for. So, any final thoughts you want to share with us?
I think that in the challenging times that almost every organization is in today, the importance of recognizing and trying to implement strategy is so key. I mean, we all know that the implementation is the real challenge. Many organizations have strategic plans, but trying to implement those plans effectively is a huge challenge. I think appreciating the overarching importance of culture is you just can't underestimate that, and it's a recipe for disaster, I believe, if you do. And I guess the last point is it's what I've said a number of times today, and that is, in my view at least, it does really all boil down to leadership, because the leader and his or her team is going to shape that culture, and it's going to create and shape that culture, and that really is where it all has to start. It's just so difficult to do this kind of organizational cultural change if you don't have full support from the leadership and ultimately work that down through the organization.
Well, thank you very much, Dr. Fairchild, for taking the time out of your busy day to be with us and to share your story with our audience. We really appreciate it.
Thank you. I enjoyed it. Thank you very much.
Great. For those of you listening out there, I would encourage you to contact us if you're interested in learning more. You can send us an email. We'll be sending each of you a follow-up email with today's archived presentation and the slides from today. We also want to let you know about our next webinar, which is going to be in just 21 days on April 20th. It's going to be part 2 of our series on culture change in healthcare, and we're going to be joined by Dr. Philip Smith of Adventist Health Center. He's going to be talking about change readiness and the implementation of computerized provider order entry systems, or CPOE, in each of their 43 hospitals. So thank you again for joining us today, and we hope to see you on a webinar soon. Thank you, and goodbye.